Hey, good afternoon, guys. We're going to run through a quick endocrine review. A couple things we're going to talk about. The biggest thing to know is that endocrine glands secrete their hormones directly in the intracellular fluid, not through any ducts. You need to know a little bit about everything as far as the different glands, your pituitary being one of the big ones we talk about, and then the pancreas as well. The three big functions we talk about, the transmission of the hormonal signal through the bloodstream to a distant target cell is your primary endocrine function. Your paracrine function, hormone signal acting on a neighboring cell of a different type. And finally, your autocrine function, secreted hormone acts on the producer cell itself or a neighboring identical cell. Serotonin is important for its CNS effects. Catecholamines are stored in the adrenal medulla. Know that steroid hormones are all derived from cholesterol or have a chemical structure similar to cholesterol. Reproductive hormones include estrogen and testosterone. They diffuse through the cell membrane. Vitamin D metabolites are also a steroid hormone. And the major sites of hormone degradation and elimination are the liver and kidneys. Thyroid hormone acts only on thyroid tissue, whereas insulin and growth hormones act all over. Hormone receptors are located either on the surface of the cells or inside the cells. They all have specific onset and duration. Effects may be generated in seconds to minutes or several hours to several days. Receptors on the outside of the cells, such as catecholamines, are fast-acting. Inside of the cells, such as thyroid, are slow-acting. Know that the number of hormone receptors is usually inversely related to the concentration of the circulating hormone. Pay particular attention to this slide. Neural responses stimulate hormones to be secreted. Smell, pain, touch, injury, stress, sight, and taste will all alter hormone release. Biorhythms are intrinsic. They may be daily, weekly, monthly, or seasonal, and they may reflect different periods during a lifetime, childhood, adolescence, etc. Negative feedback loops. After the appropriate responses occurred, it will slow down or cease hormone production. Most things are regulated this way. Positive feedback, like luteinizing hormone, results in more release prior to ovulation. Just a fascinoma. The pituitary gland weighs about 500 milligrams, so it's kind of the size of a pea, or two peas. Just know your pituitary anatomy. There's two lobes, an anterior and a posterior lobe. The blood supply to the pituitary gland comes from the carotids, so think about how highly vascular that is, and that's one of those things that leads to problems when we have pituitary surgery. Know this slide, the anterior lobe constitutes about 80% of the weight. Growth hormone regulates protein and carbohydrate metabolism. ACTH regulates growth of the adrenal cortex and release of the hormones from the adrenal gland, to include cortisol and adrenergic hormones. TSH controls the growth and metabolism of the thyroid gland. The thyroid regulates most of the chemical reactions in the body. FSH regulates ovarian follicle development and spermatogenesis. Prolactin affects mammary gland development and milk production. Know that synthesis of anterior pituitary hormones is controlled by signals from the hypothalamus. Know the important effects of panhypopituitarism. Know that patients may require thyroid hormone replacement and corticosteroid coverage in the perioperative period. Diabetes insipidus may occur. Make sure you've got vasopressin available. Worry about rapid blood loss as the case is done in a seated position, so you worry about entraining venous air, particularly for those patients. And make sure you talk to the patient before they go back about having nasal packing in place when they wake up. Make sure you know the hypothalamic defects and pituitary diseases. Pay attention to this slide. May have overgrowth of the mandible in patients with hypersecretion. May have a VQ mismatch. Exercise tolerance is limited by excess body mass and skeletal muscle weakness. They're prone to CHF, arrhythmias, and aortic aneurysms. A lot of times your EKG will show left ventricular hypertrophy, sinus tach, and or sinus ST segment, and T-wave depression, and conduction defects. These patients may require a large mask, and it may still fit very poorly because of their large nose. A lot of times they have this big, large, thick nose, and their thyroid may be enlarged as well, so start thinking about concerns for intubation. it may wind up being a fiber optic guided or assisted intubation. They also tend to have hypertrophy of the glottis, and you'll just see a general overgrowth of soft tissue in the upper airway. And you'll also see hypertrophy of the carpal ligament, which may decrease your ulnar blood flow. So if you're putting in a radial arterial line, make sure you've got good flow on both sides. Pay attention to this slide, especially the roles of ADH and oxytocin. Know that antidiuretic hormone acts primarily to increase urine osmolarity, decrease the serum osmolarity, and increase your blood volume. As a result, you have increasing circulating factors of von Willebrand factor and factor VIII, and DDAVP is a derivative of antidiuretic hormone. Things just a gee whiz for you. You generally start to have thirst at about 290 milliosmoles per liter. So in these patients with concern about deficient ADH, make sure you evaluate your lights, osmo, and volume status. And you want to correct that slowly. Anytime you're having these major fluid shifts, you don't want to try and fix it all at one time. So correct it over about 24 to 48 hours. Pay attention to the specific kind of numbers as far as your hyponatremia being less than 130 and your hypotonicity less than 270 milliosmoles. All right, talking about calcium. About 99% of calcium exists in the bony skeleton, 1% in the soft tissues and extracellular space. Know that of the calcium in the blood, 40% is bound to protein and 60% is ionized. Ionized is the most important one. So you're measuring that ionized calcium, that's what you're actually looking at. So serum calcium may not be the most accurate for you, especially depending on your patient's clinical condition. Parathyroid hormone is the principal regulator of calcium homeostasis. Calcitonin is secreted from the thyroid parafollicular cells, or the C cells, in response to an elevation of the ionized calcium. Only the free form of ionized calcium exerts physiologic effects. That's why it's important to measure that. It's important for coagulation, muscle contraction, neurotransmission, bone formation, and cell division. Normal ionized calcium is like 1.1 to 1.2. Parathyroid hormone has the strongest effect on calcium regulation. Pay attention to how calcium is regulated. So talking about parathyroid glands, about 6% of patients have 5, 13% only have 3. So just because they're supposed to have 4 doesn't mean they do. Remember, patients don't have to follow the rules and they don't know they're wrong. Hyperphosphatemia and acute hypomagnesemia will stimulate parathyroid hormone secretion. Make sure you pay attention to what the parathyroid glands do and their effect on the body. And likewise, their effect on the bone, the GI tract, and the kidney. Secondary hypoparathyroidism is a response to chronic hypocalcemia. And what you'll see on EKG is conduction disturbances, a prolonged PR interval, and a shortened QT. Pay attention to hypercalcemia. You're going to rehydrate these patients with isotonic saline solution, and then you're going to diurese the fluid out. Generally, Lasix 48 to 80 milligrams every couple hours. One thing you'll see in these patients, if they're poorly hydrated, is become acidotic. And what you see is the acidosis decreases calcium and protein binding, so you wind up having more free calcium. So think about that ionized calcium. Hypocalcemia, what you'll see is a prolonged QT interval and a shortened PR interval. They'll have Chostek's sign, which is a facial nerve contraction, and Trousseau's, which is where you inflate a blood pressure cuff on the arm above the systolic blood pressure. They'll start to develop ischemia and some carpal pedal spasms. Both of those terms are really good test questions in random fascinomas. So if you're hanging out one night and want to pimp your friends, there you go. But in the meantime, I would certainly know those for boards. Patients with chronic hypocalcemia, a lot of times will get supplemental PO. Talking about the pancreas. Exocrine glands produce products are released through the ducts. They release directly into the plasma. Know that adults generally secrete about 50 units a day from the B cells and the islets of Langerhans, and the A cells secrete glucagon. The rate of insulin secretion is primarily determined by plasma glucose levels. and there are about 200 units of insulin that are stored in the pancreas at one time. Just talks a little bit about insulin, the metabolic effects of it. Make sure you know those. We do a lot of interacting with patients that are on insulin or we have to give them insulin, so make sure you're well aware of the different types and how they work. Likewise, know a little bit about glucagon and how it works, not only as a treatment for hypoglycemia, but you may use it in the GI lab as well. And this is just some basic overview of insulin deficiency. Anesthetic management of the diabetic patients, and this kind of goes back and forth. For the longest time, we would keep these people NPO, and it just caused a train wreck. As we've moved into more ERIS protocols, they seem to be doing a little bit better with things. The other thing you kind of see come and go is the tight glycemic control, doing tight management, and its effect on wound healing. It's kind of a vogue thing sometimes, and other places it goes out of favor. Pay attention to this slide. There's no superior anesthetic techniques for diabetic patients, but regional may be more beneficial just because of there's less changes in the glucose homeostasis. Normal blood sugar 120 to 140, that also changes, sometimes 80 is normal. It just varies year to year. Hypoglycemia, generally as patients' blood glucose starts to get below 60, they start to become mildly symptomatic. We usually treat this with D10 or D50. If your patient's able to tolerate PO intake, you may consider that instead, just so they have a little bit prolonged elevation in their sugar. In a word of caution here, when we start treating blood sugars in the operating room, hypoglycemia can be catastrophic during surgery, and it's very difficult to recognize. The patients, we've removed their ability to demonstrate most symptoms. So if you're caught between the risk of having a sugar on the low side or somebody running a little high, I would generally err towards being a little bit high. It may slow their wound healing, but you won't have devastating neurologic outcomes. DKA, big thing, hyperglycemia, volume depletion, and metabolic acidosis. These patients require large amounts of fluid just due to the volume depletion. And along with that, a lot of times they've had significant electrolyte depletements as well. So we're generally not going to take DKA patients to the operating room if we have a choice. Likewise, we're not going to take patients with HHNS to the operating room. All right, moving on to the thyroid. Know that T3 is more potent and less protein bound. An increase in metabolic rates results in an increase in metabolic consumption and an increase in CO2 production, which is going to increase your minute ventilation. So if you see those patients hyperventilating, there might be a reason behind it. Pay attention to the signs of hyperthyroidism. This is a good one for test stuff. Big thing is the temperature intolerance, especially heat. They may have acute weight loss. When you look at these patients, the exophthalmos or the goiter a lot of times will jump right at you, and they may have a little bit of a fine muscle tremor as well. Anesthetic considerations for these patients. Evaluate them as possible to determine the level of disease process. It's a fairly straightforward case as long as they don't have a significant goiter or concerns for airway compromise. Intraoperatively, you may consider an armored ET tube. They may also use a nerve monitoring tube. As a result of that, you may not be able to use any neuromuscular blocking agents. So it may be done as a TIVA or just avoiding any muscle relaxants at all. Generally, the biggest thing you worry about in these patients is going to be thyroid storm, hyperpyrexia, tachycardia, altered mental status, and hypotension. And you're going to treat it pretty straightforward: hydration, cooling, something to control the tachycardia, esmolol, or IV propranolol if available. Big things for you to think about surgical complications-wise. Subtotal thyroidectomy is accompanied by several potential complications. Pneumothorax, depending on the location of the thyroid itself. Hypoparathyroidism, formation of a hematoma, especially in the neck. We worry about this in the postoperative period as they start to expand. and then recurrent laryngeal nerve palsy. There's some surgeons that will want to have the patient talk or cough before they leave the operating room to make sure they don't have any nerve injury. Hypothyroidism, a lot of times they're just treated with infusion of T3 or T4 depending on the level of symptoms. Anesthetic considerations, just the biggest one's just delayed gastric emptying. And try and have it corrected before you take them to the operating room. If you're not able to correct it, they probably shouldn't go to surgery unless it's emergent. For those patients, a lot of times you'll use ketamine for induction or a combination of etomidate and propofol just for hemodynamic stability. Adrenal gland, these are a lot of times now being done robotically, which makes life a little bit easier. And the other thing is they're often an incidental finding. The patient comes in for something and they get a CT of the abdomen and figure out they have a large adrenal gland. The big thing we worry about is chemical imbalances for these patients that can result in problems. You can have so many interactions with them. Moving on to glucocorticoids, ACTH is the principal regulator of glucocorticoid secretion, and generally you produce about 20 milligrams a day of cortisol. Catecholamines, about 80% of the adrenal catecholamine secretion is in the form of epinephrine. It's mainly regulated by the cholinergic preganglionic fibers of the SNS, things that will stimulate hypotension, hypothermia, hypoglycemia, hypercapnia, hypoxemia, pain, and fear. So think about your fight or flight system there in effect. Clinical manifestations of mineralocorticoid excess, hypertension, hypervolemia, hypokalemia. You want to make sure these patients have adequate fluid status and any electrolyte abnormalities have been corrected. And if you have aldosterone excess, you'll see Conn syndrome, another one of those good board questions. A little bit more about catecholamine excess, particularly talking about pheochromocytoma. It's a catecholamine secreting tumor. And what you may see with these patients or undiagnosed patients, they may have post-op hypertension. Think about them possibly being volume overloaded. Or the other possibility is there may be another pheo somewhere that was not detected and addressed, or they may not have removed the whole thing. Anesthetic considerations primarily is just making sure you have adequate adrenergic blockade and volume replacement, good IV access and invasive monitoring, and how are we going to treat intraoperative hypertension. These patients, especially if it's an undiagnosed pheo, will become profoundly hypertensive. I'm talking about blood pressures in the 300 systolic. So always bear in mind if they're working anywhere near the kidney or you're concerned about a tumor or mass anywhere near the kidney, that is a possibility. And what you may see in these patients is post-resection, they become profoundly hypotensive. So you may go from one extreme to the other. When you're thinking about blood pressure medications, think about something you have the ability to remove quickly. You want to try and avoid long-lasting stuff if at all possible. All right, thank you guys very much.